welcome to the usmle channel, and this is the ICU series. In this series, I'm going to cover the most common cases you are going to encounter during your ICU rotation, during your internal medicine residency. I'm going to crack open these cases like never seen before. So let's begin. I present two cases to you side by side. Case number 1. Mr. Young Dude presents to the emergency department with complaints of polyuria, polydipsia, abdominal pain, nausea and vomiting for the past few days. He does complain of having flu-like symptoms last week. On physical examination, you notice a ketone breath. He appears lethargic. He has tachycardia. He has got an elevated respiratory rate. His blood pressure is a little bit on the lower side. On labs, you find out that the patient's got a blood glucose of 600, beta hydroxybutyrate level of 5, high anion gap metabolic acidosis, a bicarbonate level of 7, and your venous blood gas shows a pH of 7.00. Case 2. Mrs. Older Heavy, with a past medical history of diabetes mellitus, was brought in by her home health aide as she was noted to be obtunded and minimally responsive at home. The patient ran out of her diabetes medications over 3 days ago and could not refill due to heavy snowstorm outside. On physical examination, you note that the patient has a GCS of 7, the labs show a blood glucose level of over 1000, a serum osmolality level of 350, pH is normal with 7.4, beta hydroxybutyrate is negative, and an anion gap of 10, which is normal. Alright guys, so let's dissect these two cases. Case number 1, Mr. Young Dude. Mr. Young Dude is presenting to us with complaints of polyuria and polydipsia. Alright, and on physical examination, you find out that he's got this acetone breath coming from his mouth. And along with that, you also find out the man is actually tachycardic, his blood pressure is borderline low. And then on labs, you find out he's actually got a very high blood glucose level, a blood glucose level of about 600. And apart from that, you also find out he's got an elevated beta hydroxybutyrate levels. His pH is 7.00, he's severely acidotic, and he also has a high anion gap metabolic acidosis. When you put all these things together, what do you have? You have a condition called diabetic ketoacidosis. Alright, let's go on to case number 2. Case number 2, Mrs. Older Heavy. She is a known diabetic who lives at home with a home health aide, and she was found to be obtunded and unresponsive. So no real complaint from her, however, she's become unresponsive. Alright, and this patient is brought into the ED, and on physical examination, she's got a GCS of about 7. So you're trying to wake this lady up, but she's minimally responsive. And on labs, you see that she has a blood sugar level greater than 1000, and she also has an elevated serum osmolality levels. However, her pH appears to be normal at 7.4, and her beta hydroxybutyrate is not even detected. And when you put all of these things together, what do you think this patient has? She's got another condition that we call a HHS, which stands for hyperglycemic hyperosmolar non-ketotic coma. Since I've given you guys the most typical presentation of DKA and HHS, we could leave it right here because you could easily diagnose these patients and go directly to management, because that's what's important in the ICU. But that's not the point of all of this, is it? The point of all of this is for you to understand exactly why each and everything happens. Once you learn that part, you will be able to manage your patients better. So let's go back in time and learn our physiology and biochemistry of DKA and HHS. It is time to dig deep and understand everything about DKA and HHS. DKA versus HHS. Why does it happen? Well, DKA, it's pretty simple. Your pancreas is not working. And if your pancreas is not working, then you don't have insulin. Your beta cells of your pancreas normally produces insulin. And what happens is, Mr. Young Dude, a young guy, right? Why is his pancreas not producing insulin? Well, maybe he had a viral infection that actually caused an autoimmune reaction, and the autoantibodies went and fried up the pancreas, leaving no beta cells behind, and therefore this patient does not have insulin. Oh, that explains it. Very good. Let's go into HHS. HHS actually happened in Mrs. Old Heavy. She was old and she was heavy. That's two important things that we have to note down, right? It's not a young patient, it's an older person, and an older person who's actually got some form of obesity going on. And if you look at this image, you actually realize that the patient actually does have a working pancreas. So the problem is not the production of insulin. Insulin is actually present, and that is not the problem. Then what is the problem? The problem is the insulin has to bind to certain receptors in order to push the glucose into cells. But these receptors are not working. So what's the point of actually having a lot of insulin when it cannot work? Essentially, it's the same thing, isn't it? Mr. Young Dude does not have a pancreas and therefore does not have insulin, whereas Mrs. Old Heavy has a working pancreas, produces insulin, but the insulin cannot work because the receptors do not respond to the insulin. Well, whichever path we took, whether it was DKA or if it was HHS, we eventually lead to the same endpoint. The endpoint is no functional insulin. If you do not have a functional insulin, what do you got? You got a ton of sugar in your blood. Alright guys, if you guys want to be the star resident in managing DKA and HHS, it's not enough if you just learn the guidelines and know how to manage the patient. You must actually dig deep and understand exactly the fundamentals of why a DKA or HHS occurs. So what's the main problem with the patient with DKA or HHS? As we already said, we know that the patient with DKA or HHS is going to be having either decreased insulin or no insulin, or there is insulin, however the insulin cannot bind to the receptors and there is resistance to it, and therefore there is no functioning of insulin. So that's your basic problem. There is no insulin, or there is insulin but it's not functioning. That's it. So when that happens, what's going to happen in your body is exactly this. So if you look onto your right side here, if you have decreased insulin, you are going to have your counter-regulatory hormones such as glucagon, cortisol, epinephrine and growth hormone to be elevated in the blood. So what happens is when these hormones actually goes up in levels, what it's going to do is you will see that it is actually going to stimulate two pathways. Alright, number one, it's going to stimulate your glycogenolysis. Remember, in biochemistry, when you're first off starving, when you stop eating, the first 12 hours, glucose is produced into your blood by the process of glycogenolysis. So that's your first 12 hours. So if you do not have insulin and a lot of the other hormones, then you're going to have stimulation of glycogenolysis, which is going to break down glycogen and release glucose. Alright, and number two, it is going to be stimulating another pathway which is known as gluconeogenesis, which is essentially your main pathway that's going to produce glucose and release it into the blood. Nevertheless, I also want you to focus right up here, which I call GLUT4 receptors. As you guys know, there are 4 types of GLUT receptors. Essentially what it does is transportation of glucose into cells. If you look at GLUT4 is actually present in adipose tissues and muscle cells, and what it does is it actually transports glucose into your adipose tissues as well as your muscle cells. But GLUT4, unlike the other GLUT receptors, will require insulin stimulation. When you have insulin stimulation, you will have a lot of GLUT4 receptors, and this is going to reabsorb a lot of glucose into storage sites. So if you do not have insulin, you see the problems that are occurring. Number one, you're not going to have GLUT receptors to uptake the glucose into the cell, and you're stimulating two pathways which is going to release a lot of glucose into your blood. There you go. Now you're going to have a lot of glucose in your blood. So that's your main picture that you always see with the patient with DKA and HHS. They are going to have high levels of sugars. However, as I already mentioned, right, you're going to have about 600 in DKA, whereas about 1000 in HHS. So why is there such a discrepancy? Why do people with DKA have less sugar in their blood when compared to HHS? It's actually a very fundamental concept. A lot of people actually don't think about it, but for me, I have to think about it because that's how I remember things. So let's talk about this. Who gets DKA, guys? A young person or an old person? A young person, right? Whereas HHS occurs in an older person. Now, when you look at a person who's presenting with DKA, often they are young kids. When a young kid is presenting, do you think this young kid is going to have good functioning kidneys? Yes, right? There's no reason for the person to have a bad functioning kidney at a very young age. Even though they have diabetes, they're just being diagnosed with diabetes at that age. Alright, whereas if you take a patient with HHS, this is a person who's got long-standing diabetes, who's been on tons of oral hypoglycemic agents. The patient has been on insulin for a very long time. So what you have to realize from this is two things. Number one, as a person ages, even if the person did not have diabetes, what happens to their kidney function? Their kidney function declines. It's a simple concept of aging. As a person ages, your kidney function will decline, which means your GFR will go down. Now you throw diabetes into that, and the diabetes is going to cause all sorts of damage to the kidneys, as you guys already know. So when you have a damaged kidney because of a long-standing diabetes, what's going to happen to the glomerular filtration rate? It's going to go down. So when you want to understand why there's less sugar in the blood in a person with DKA, whereas very high sugars in a person with HHS, is due to GFR, guys. It's due to GFR. So a young person is able to pee out a lot of sugar in their urine, and therefore they will have less sugar in their blood. Whereas the person with HHS got a bad functioning kidney, what's going to happen is they won't be able to pee out all that sugar in their urine, and as a result you're going to see a lot of sugar in your blood. That's it. So this explains why you're actually going to get this discrepancy in DKA versus HHS. So now that we got that covered, let's keep moving on into our story. So when coming to the concept of volume depletion, there is also discrepancy if you look at DKA versus HHS. In DKA patients, you're going to have about 7 liters of fluid deficit, whereas if you look at a person with HHS, they're going to have about 9 to 10 liters of fluid deficit. The reason for this discrepancy is also pretty straightforward. If you look at a person presenting with DKA, they are often going to have a lot of symptoms because they're having a lot of acidosis going on in their body. They got a lot of lactic acidosis production, and these young people are able to actually identify their symptoms earlier, and as a result they would present to the hospital much sooner as compared to an HHS person. If you look at a person with HHS, oftentimes somebody else is going to bring them because they are obtunded, they are becoming unresponsive, which means an older person who's not being able to realize what's going on, oftentimes they might be bedridden, and as a result they present much later. So as long as the acute event of either DKA or HHS takes time for the patient to get to the hospital, the longer they wait outside, the longer their fluid deficit is going to be. So therefore HHS presenting later on is going to have a much higher fluid deficit when compared to a person with DKA. Nevertheless, 7 or 9, guys, the patient has fluid deficit. That's very important for you to realize, okay? Patients are going to require a lot of fluids when you're going to manage them. So fluid deficit, essentially volume depletion, is the main problem that's going to be happening in a patient with DKA or HHS. So now, once you have volume depletion, what's going to happen is you're going to have decreased perfusion to your tissues. And if you have decreased perfusion to your tissues, obviously you're going to give less oxygen to your tissues. If you give less oxygen to your tissues, are you going to do anaerobic glycolysis? Yes, you are. And if you're going to do anaerobic glycolysis, you are going to be producing a lot of lactic acidosis. So as you see, all patients with DKA and HHS, you will see that they are going to have lactic acidosis. And what is the reason for that? There's two reasons. One of them is the presence of volume depletion causing anaerobic glycolysis. That's it. Alright, so now what else is going to happen as a result of your volume depletion? What's going to happen is, if you have less volume in your body, in physiology you know that you're going to activate your RAS system, renin angiotensin aldosterone system. And again, one more important point I want to remember, all patients with DKA and HHS are going to be very much depleted in potassium in their body. And one of the reasons why they're going to be depleted in potassium in their body is because when you activate your RAS system, you're going to eventually cause stimulation of aldosterone. And remember, aldosterone is going to reabsorb sodium and water in exchange for potassium and H+ ions. So if you're going to push out, secrete out potassium in your urine, you're going to lose a lot of potassium in your urine. And if that's the case, that explains why patients with DKA and HHS are going to be intracellularly depleted in potassium. Alright, that's the physiological explanation of what's going on in these patients. However, there is also a biochemical explanation for what's going on in this patient. So let's look at that for a second. If you look at a person with DKA and HHS, as we already spoke of, the discrepancy between your insulin and your counter-regulatory hormones, you see that this counter-regulatory hormones is actually going to stimulate a certain enzyme in your adipose cells, and the enzyme that is going to be stimulated is a hormone-sensitive lipase. If you stimulate stimulate hormone sensitive lipase, you actually essentially gonna break down fats from your adipose tissues. And if you break down fat from your adipose tissues, you will release free fatty acids. And these free fatty acids will undergo another process which we call beta oxidation. And when you do beta oxidation, guys, you will produce keto acids. You will produce keto acids such as beta hydroxybutyrate, acetoacetate, and acetone. Now, I want you to remember these things because if you look at it, a lot of patients with DKA, you will see that those patients are actually going to have something called a high anion gap metabolic acidosis, HAGMA, high anion gap metabolic acidosis. By the time you get to your third year, guys, you won't be saying high anion gap metabolic acidosis. You've gotten to a point, you're so cool now that you can actually say HAGMA. Alright, so what is HAGMA? Is this high anion gap metabolic acidosis. What gives rise to this high anion gap is the presence of ketoacidosis and a component of lactic acidosis. So both of them are actually going to be contributing to presence of a high anion gap metabolic acidosis. Now, you see that there is going to be a high anion gap metabolic acidosis and ketoacidosis really only in patients with DKA, whereas HHS, you will not see this picture. The HHS patients normally will have some component of lactic acidosis because there's volume depletion, but the step of ketoacidosis and a high anion gap metabolic acidosis technically will not be present. The reason for that is, guys, in patients with HHS, you actually have insulin. Alright, that's the trick. You actually have insulin. The presence of insulin actually prevents the occurrence of beta oxidation of free fatty acids. So the presence of insulin is the trick to remember why you're not going to get ketoacidosis and high anion gap metabolic acidosis. That's it. So once you know these facts, now you're going to be able to approach your patients much better than a person who does not know these facts. Alright guys, so I think this pretty much sums up what really goes on in your patient with DKA and HHS, and you've completely understood it, even as a PGY3 resident in the ICU, having done biochemistry and physiology a long time ago. But now you have it with you to approach your patients in a much smarter way than everybody else. But no understanding is complete until you've really understood biochemistry. So now some of you are probably wondering, wait a second, there is another interesting concept about why you are going to get higher levels of beta hydroxybutyrate in patients with DKA when compared to acetoacetate, and why do you get lactic acidosis apart from volume depletion being the cause? And if you're thinking that I'm going to explain it, you're absolutely right. So let's dive into the biochemistry of ketoacidosis. Alright guys, so now let's talk about the biochemistry of diabetic ketoacidosis. Why does it all happen? Well, it's all explained back on this board. So let me take you through a journey of understanding the biochemistry of DKA. So you guys already have the concept of less insulin and increased counter-regulatory hormones, and this is going to stimulate an enzyme which is called hormone sensitive lipase. Now the duty of hormone sensitive lipase is to break down triglycerides that is stored in your fat. So you're going to break down these triglycerides to release free fatty acids and glycerol. So once you release these free fatty acids, the fate of the free fatty acids starts here. What happens is the free fatty acids is actually taken up into the liver, and it's going to undergo a very important process, guys. I want you guys to think of free fatty acids like charcoal, guys. You're going to take this charcoal and it's going to undergo a process to produce energy, and this energy is eventually going to be used for multiple different things. So let's look at this. So if you take this free fatty acid, as I said, charcoal is going to undergo a process called beta oxidation. By beta oxidation, you're producing a lot of energy. Energy is NADH. So I want you guys to really understand what's going on here. You are going to be producing high levels of NADH, and this NADH is going to be used for a lot of things in your body, but it is also going to cause certain complications along the way. So let's go into the story a little bit more deeper. So as you guys can see, the free fatty acid undergoes beta oxidation to produce acetyl-CoA. Now this path on the right side is going to be called ketogenesis. So this acetyl-CoA is going to undergo a series of steps by getting converted to HMG-CoA, then acetoacetate, beta-hydroxybutyrate, and acetone. Now these are your three key ketone bodies that you're going to see in your patient with diabetic ketoacidosis. So three things, right? Acetone, acetoacetate, and beta-hydroxybutyrate. Then why do you get a higher level of beta-hydroxybutyrate? Well, it's all to do with your chemical reaction. As I said, you do produce a lot of energy such as NADH. It is required for the body, but it also causes certain different changes in your body. So as you guys can see, increased NADH actually favors the formation of beta-hydroxybutyrate. For instance, if you had more NAD, you would actually favor the formation of acetoacetate, but that's not the case here. You actually have a lot of NADH, and that is going to favor the formation of beta-hydroxybutyrate, guys. That's it. So now you understood why you see much higher levels of beta-hydroxybutyrate in patients with DKA when compared with acetoacetate. Okay, so fine, you understood your burning of charcoal, which is beta oxidation, to produce energy. Why do we need this energy, guys? What is the purpose? What is the point of generating all this energy? I hope you guys realize something here. DKA is very similar to a starvation state in your body, right? When you're starving, you have less insulin and you have high levels of your counter-regulatory hormones. We have come to a point of realizing that when we are starving, our body's duty should be to produce glucose. Well, how do you produce glucose? Well, there's two processes. Number one, for the first 12 hours, I've already told you it's going to be glycogenolysis. But the bigger process, which is the mother of all processes to produce glucose, is going to be called gluconeogenesis. It is the genesis of glucose. It is happening in the liver and it pours out all this glucose. Well, it is a big engine. Your liver is a beautiful engine that is able to do this process of gluconeogenesis, but it requires energy. The power to actually run your gluconeogenesis comes from your beta oxidation of fatty acids. So that's the reason this actually happened. So you did your beta oxidation, you produce a large amount of NADH, and this NADH is going to be used to power your gluconeogenesis pathway. So now I'm going to simplify the gluconeogenesis pathway for you so you can understand what really happens in DKA. Well, we already know that gluconeogenesis is the powerhouse or the engine that is going to be producing glucose. Alright, this is the powerhouse, which is gluconeogenesis, that's going to produce glucose. So any powerhouse, in order to produce glucose, you need to provide substrates, right? What are the substrates we're going to use? Is going to be glycerol 3-phosphate, lactic acid, and alanine. Alright, so you have your three substrates, which is going to go a multiple number of steps essentially to form glucose. But if you look at this pathway, you would realize something. The presence of high levels of NADH actually influences certain steps to go in the opposite direction. It does not mean that a patient with DKA is going to have such high levels of NADH that they're not producing glucose. That's not the point I'm trying to make. The point I'm trying to make is certain substrates formation is actually favored because of the presence of higher levels of NADH because of your beta oxidation of fatty acids. So if you look at this one important step, guys, when you look at this one important step, which is lactic acid getting converted to pyruvate, there is NADH and NAD involved. And you can also notice here that when you have a higher level of NADH, you actually favor the opposite direction and you will form more lactic acid. So this is the other reason why you're actually going to get lactic acidosis in your patient with DKA. Isn't that just beautiful, guys? Perfect. Alright, now since you understood why you're going to get lactic acidosis in your patient with DKA, I have to give you this cool integration fact, guys. Let's talk about another very similar scenario which is often going to be seen in your ICU as well. Think about an alcoholic. If you see alcoholics, you often seen that alcoholics can also go into alcoholic ketoacidosis. Let's talk about why that happens. Think about it. If a person was drinking alcohol, you metabolize alcohol using this pathway. So what happens is when you metabolize alcohol, it goes from alcohol to acetaldehyde and then finally acetate. The conversion from alcohol to acetaldehyde is by an enzyme known as alcohol dehydrogenase, whereas conversion of acetaldehyde to acetate is by another enzyme which is called acetaldehydrogenase. However, when you look at both these steps, you notice that you're producing a high level of NADH. So NADH is playing a significant role here, guys. That's the reason they say whenever you drink alcohol, you actually produce calories, you actually produce energy, because when you metabolize alcohol, you actually do produce NADH. Alright, so fine. Now you have high levels of NADH in your patient who is an alcoholic. Now what problems is this presence of large amounts of NADH in alcoholics going to pose for those patients? Think about this. I'm going to give you a concept. If you look at a patient who is an alcoholic, do you think these alcoholic patients are going to be eating? No, they're not, right? They're going to be drinking all the time, that they're not going to be eating. As a result, you would expect them to be hypoglycemic. So if they are hypoglycemic, what's going to happen, guys? You are going to take these same steps. Patient is going to go into a starvation state, and as a starvation state, you're obviously going to have your increased counter-regulatory hormones. You're going to stimulate this entire pathway again, and you're going to produce high levels of NADH. The important thing though is patient with alcoholism, apart from the regular process that happened, now you have even more NADH being produced because of your alcohol metabolism by itself. So you're going to have much higher levels of NADH in a person with alcoholism as compared to somebody with DKA, because you do not have the factor of alcohol metabolism in DKA. So what happens in these alcoholics is, because you have such high levels of NADH, the three important steps that we spoke of in gluconeogenic pathway is actually favored in the opposite direction. So you will actually form more of glycerol 3-phosphate and lactic acid as opposed to going in the right direction to produce glucose. So a lot of alcoholics, their gluconeogenic pathway is actually favored in the opposite direction and not in the direction of formation of glucose, and as a result they will be hypoglycemic because of that reason. So that's the important point you guys have to realize. It is not just the fact that they're not eating, but it is not eating plus your gluconeogenesis does not happen efficiently because you have too much NADH. So now you know why the alcoholics are going to be hypoglycemic and how alcoholics can actually result in formation of ketoacidosis. So now you have understood the entire concept of diabetic ketoacidosis, alcoholic ketoacidosis, and starvation ketoacidosis. It's all to do with these steps, and now you have mastered it for life. Now that you've understood all that happens with DKA, you need to understand what happens in HHS as well. Now in HHS, when you want to diagnose a patient, you normally are going to check a certain different type of level in your blood, and this is going to be called your serum osmolality, guys. In order for you to diagnose a patient with HHS, you must have a very high serum osmolality level. Normal serum osmolality, as you guys already know, was about 270 to 300. Now how do you calculate your serum osmolality and why is it increased in patients with HHS? So let's look at this equation over here. If you look at serum osmolality, it is 2 times sodium plus glucose divided by 18 plus BUN divided by 2.8. Now there are reasons why it is going to actually be elevated in your patient with HHS. First off, what did I tell you about patients with HHS? Are they going to be more volume depleted than DKA patients? Yes, they are. And the reason was because they presented much later as compared to a DKA patient. So if you have a lot of volume depletion, what's going to happen to your serum sodium, guys? Your serum sodium is actually going to go very, very high. So you're going to have a very high level of serum sodium in your patient with HHS. So that's going to be contributing to increased serum osmolality. Let's look at number 2. What about your glucose? If you look at a person with HHS, they had much higher glucose levels as compared to DKA patient, and the reason there was because older patients have a low GFR and patients who have been diabetic for a long time have diabetic nephropathy, both of which is going to be contributing to decreased elimination of glucose in your urine and as a result increased blood glucose levels. So your glucose levels are going to be very high in patients with HHS as well. So that's going to be contributing to it as well. Now, number 3, we've got BUN. As I already told you, patients with HHS have long-standing diabetes, guys. If you have long-standing diabetes, what's going to happen to your kidney function? Your kidney function is going to be declining. If you have declining kidney function, can you eliminate your nitrogenous waste products in your body efficiently? No, you can't. So your BUN levels are also going to go up. So because of these 3 factors, you are actually going to have a high level of serum osmolality in your patient with HHS. In order for you to diagnose a person with HHS, you must have serum osmolality greater than 320, guys. 320 is gonna be your magic number. So just like DKA, you had a high anion gap, whereas in patient with HHS, you have an increased serum osmolality. This is important for you to remember, because when I come to talking about bridging your insulin, your serum osmolality has to have normalized. Essentially, it must be below 320. So 320 serum osmolality meets diagnostic criteria for HHS. It is going to be important when you're going to be bridging your patient with subcutaneous insulin, which we are going to get into in just a minute. Alright guys, so now that you understood everything that goes on in DKA and HHS, now we can take care of our patient. So we have our patient Mrs. Older Heavy and Young Dude. Now despite me actually going in and cracking exactly what happens in DKA and HHS and explaining all the differences that actually happens, I want to tell you guys a little truth now. In actual clinical practice, you'll often see there's a considerable overlap between the two. Alright, so most patients who have HHS and actually present to your ICU, you'll always see that they actually do meet criteria for DKA as well. So you'll see that there's considerable amount of overlap. It doesn't matter. The important thing is the treatment is essentially going to be the same. So it doesn't matter to me if it is DKA purely or HHS purely, or it has got a mixed picture. My treatment is the same, so it doesn't really matter. However, understanding why each of things happen is the purpose of my lecture. So good, now you understood everything. However, now we're going to take care of our patient. Let's bring the books into your ICU, guys. So now we have our patient, Mr. Young Dude and Mrs. Older Heavy. So let's put in our workup. What labs are we going to order? So let's look at the labs that I'm going to place in my patient, right? So number 1, I would need a CBC. Well, why do I need a CBC? Well, the reason is anybody who's coming with HHS or DKA are not just going into these things just because their pancreas suddenly decided to not work, or Mrs. Older Heavy just decided not to take her insulin. She might have taken her insulin, but yet she went into a hyperglycemic state. Why does this happen? Oftentimes the important truth that you need to understand is there is always a trigger, guys. There is always a trigger. One of the most important triggers is going to be infection. So you will always look for infectious sources in your patient with DKA or HHS. So CBC is important because it's going to tell me the WBC count. If my WBC count is elevated, then it tells me, well, there might be some form of infection going on and I have to get a workup done. And then obviously you want to get a hemoglobin level to see how the patient's hemoglobin is as well. Alright, number 2, I'm going to require a complete metabolic panel. There are a few things that I'm interested to see in a complete metabolic panel. Number 1 is my sodium, guys. Sodium becomes a very important part of your management of DKA and HHS. I will get to it in just a second. But you also know that sodium is going to be important because you know that sodium is going to be used to calculate your serum osmolality. So in order for you to calculate your serum osmolality, you're going to require sodium levels. Number 2 is potassium, guys. Potassium is so important. I've already explained to you that a patient with DKA or HHS are going to be intracellularly depleted in potassium. And what was the reason, guys? Volume depletion, activating your RAS, stimulating your aldosterone, and potassium secretion in the urine. Alright, that is one reason, but also there's a lot of shift. Acidosis in your body is going to cause a shift of potassium from intracellular to the extracellular space. I will explain that in just a second, but for now I want you to remember potassium depletion is happening in your body. Just because you see a high level of potassium in your blood does not mean it is the same within the cells. So patients are potassium depleted in both DKA and HHS. Alright, what about BUN? As I already told you, HHS patients are going to have an elevated BUN, but nevertheless, DKA patients could also have elevated BUN, and BUN is important because you are going to be calculating your serum osmolality. Alright, what about creatinine? As I said, when you have volume depletion, you can cause an acute kidney injury. So therefore, creatinine becomes a marker that you're going to be using to see if your patient actually meets criteria for an acute kidney injury as well. Alright, then we've got a VBG. Now, venous blood gas becomes a very important test in these patients. Reason is because in order for you to diagnose a person with DKA, the patient must meet certain criteria. One of the most important criteria is the pH has to be less than 7.3. Your pH has to be less than 7.3, indicating the patient is actually acidotic. And you guys already know why the patient is acidotic. The patient is acidotic because there's elevation of beta hydroxybutyrate, acetoacetate, and lactic acid. So clearly you have to get these levels as well. Beta hydroxybutyrate, you need to get a lactic acid level as well. So VBG becomes so crucially important because it is what is going to be diagnosing your patient with DKA. And obviously you'll find out your beta hydroxybutyrate levels are going to be elevated, and it's also required for diagnosing DKA. Lactic acid levels will be elevated in both DKA and HHS for the same reasons I explained to you before. So it is important for us to check those levels as well. Alright. Next, you're also going to have bicarbonate level. Now, bicarbonate level in your serum is always going to be more accurate when compared to your blood gas. Alright, so when you look at your bicarbonate level in your blood, your diagnostic criteria to meet in order to diagnose somebody with DKA is the patient must have a bicarbonate level less than 18. So 18 is your magic number for your bicarbonate. It needs to be less than 18, indicating that the patient is actually acidotic. Your normal bicarbonate level is 24. Alright, next we're going to go on to your serum osmolality. So serum osmolality, you could calculate it using your equation which I've shown you before, which is 2 times sodium plus glucose divided by 18 plus a BUN divided by 2.8. Alright, so you can get a serum osmolality level by using this equation. Next, you're also going to get a blood glucose level or a finger stick. You can either do from the blood, or you could do a finger stick and get a bedside blood glucose level. And you guys already know that patient with DKA is going to be about 600, whereas patient with HHS is going to be in the thousands. And you guys already know the reasons why this actually happens when compared to everybody else who just memorizes and do not know why it actually happened. Alright, so moving on to this side of the board, we have to do a chest x-ray. A chest x-ray and a urine analysis. As I said guys, one of the most important reasons why somebody actually goes into DKA and HHS is infection. So when you think of infection, if a person's got a fever, elevated white count, your basic workup must constitute a chest x-ray because you're looking for a pneumonia. You're looking whether there's an infiltrate or a consolidation somewhere, and therefore pneumonia could actually be precipitating the patient to be having a DKA or HHS. The next part of a regular sepsis workup is going to be getting a urine analysis. The reason is the lungs and the urine are the most common sites of infection. So you will get a UA. In the UA, you're going to be looking for 3 things. You're going to be looking for WBC count, you're going to be looking for nitrite positive or not, or leukocyte esterase positive or not. All 3 of which are going to be indicating if there's a presence of infection or not. And if there is, if the patient actually has a WBC count greater than 15, essentially meaning the patient probably has a urinary tract infection. This is not actually the case if the patient has an indwelling Foley catheter, because you can have irritation and elevated WBC cells just by the presence of the Foley itself. Next, if your urine analysis is actually positive, it's only at that point that you would do a urine culture. You would never ever do a urine culture if you do not have a positive urine analysis. There's no reason to culture somebody's urine if it is not positive for an infection, guys. And if the patient has a positive UA, you obviously want a urine culture, because this is going to tell you what specific organism it is. You can tailor your antibiotic to your specific bug. Alright, another important thing is you must get blood cultures, guys. You must get 2 sets of blood cultures from 2 different sites of the body, and you must use sterile gloves when you do this procedure. Reason is you are going to cause contamination of your blood cultures, and it is going to give you a false positive result. So you want to use sterile methods and get 2 sets of blood cultures from 2 different sites, guys. That is very, very important. Alright, so once you've done your basic workup, such as your chest x-ray, urine analysis, and your blood cultures, and for instance you do not find a source of infection, at this point you have to dig deeper, because if your patient has a fever, has an elevated white count, there is something suggestive that this person might have an infection, but you looked at your 2 first most common sites and you did not find the infection. Obviously the next step is to go for the CT abdomen, guys. You need to do a CT abdomen because most times you will see that the patient might have an acute cholecystitis, might have some form of abscess within the belly, or might have some form of cholangitis, might have some form of diverticulitis. There could be some infection that's going on in the belly, so therefore you will have to do a CT abdomen as well. I've often noticed that the patient can actually have another source of infection which is often missed, which is a rectal abscess, guys. So therefore you should always think of doing a rectal exam, looking for a rectal abscess which might be hidden and may be the source of infection in your patients. Another thing, a very thorough skin examination, because most of these patients who are coming in with HHS are often older, they're from nursing homes, they could have a lot of pressure ulcers which might be infected. Therefore head to toe a thorough skin examination becomes a very crucial part of your investigation for your infection. Apart from that, you could also look if the patient is having some form of cellulitis or some form of infection within the web spaces of the toes as well. So very thorough skin examination becomes very crucial. Now if you've done all that workup and you still cannot find an infection, and if you do have suspicion for possible meningitis, at that point you must consider doing a lumbar puncture as well. My point I'm trying to make about this whole sepsis workup is anybody with DKA and HHS may have an infection, so look for it. Alright, if you don't find an infection, could you use broad spectrum antibiotics because your suspicion is extremely high? Absolutely, go ahead, give the patient broad spectrum antibiotics until you find a source of infection. And another important thing, especially in winter months, remember, always get a flu swab because the high risk of influenza in these patients as well. Alright, so infection becomes one important cause of the precipitation of DKA and HHS. Another important one is myocardial infarction, guys. A lot of patients who are diabetic are prone for coronary artery disease, and therefore they could actually have an acute myocardial infarction that has tipped them over into DKA or HHS. Therefore get a EKG and a troponin levels as well. And if the patient actually is having an acute myocardial infarction, you will treat the patient accordingly based on my other lecture. A third important cause becomes acute pancreatitis. Oftentimes you would see that the patient actually has very high levels of lipase and amylase. So always look for acute pancreatitis. So it will be good idea for you to get a lipase and an amylase level. You have to have more than 3 times the upper limit of normal in order for you to meet diagnostic criteria for acute pancreatitis. Also, last but not least, guys, depending on the patient population you're dealing with, if you think that your patient might be into some form of substance abuse, it'll be a very good idea for you to get a urine toxicology as well, looking for any form of substances the patient may have abused prior to arrival to your emergency department. There you go. So this covers your basic workup that you're going to be using in order to work your patient up when they present to you with DKA and HHS. Alright guys, so now let's just recap the findings you're supposed to be seeing in order to diagnose your patient with DKA and HHS. First off, just let's look at this table. If you look at this table, you'll realize that a patient with HHS has much higher sugar levels, greater than 600, greater than 1000. Alright, whereas DKA DKA patients, ideally greater than 250 alone is enough for them to actually present with DKA, but more oftentimes you would see it's going to be in the 500 to 600 levels. Alright, now important thing I want you to focus on next is going to be the patient's arterial pH. Now you don't have to get an arterial pH, a venous blood gas could also give you the pH, which should be fine for us to diagnose the patient with DKA. Now the important thing is for diabetic ketoacidosis, you must notice that the pH must be below 7.30. Now you can actually classify into mild, moderate and severe based on the acidosis. If you have a pH between 7.25 to 7.30, this is called mild, whereas moderate you will see between 7 to 7.24, and if it is severe you will have a pH less than 7. So important thing is your pH. So you will need your venous blood gas or an arterial blood gas to determine the degree of acidosis. Next important thing is also the serum bicarbonate. Number one important point to realize first is the patient must have a bicarbonate level less than 18 to be diagnosed with DKA, and then you basically go ahead and classify them saying, well, if it's between 15 to 18 it is mild, it is between 10 to 15 it is moderate, and less than 10 is severe. And you will see that the patients are going to have positive urine ketones, you will see beta hydroxybutyrate levels elevated in the blood, and lastly another important parameter is the presence of the anion gap, guys. Normal anion gap is about 10 plus or minus 2. So a patient with DKA is always going to have a high anion gap, metabolic acidosis. So a patient with DKA, the most important parameters are going to be patient's pH, serum bicarbonate and your anion gap. These are your three most important parameters. If you go into HHS, you will realize that the patient's blood glucose will be elevated. However, pH is greater than 7.30 and your serum bicarbonate is greater than 18, and the patient's anion gap, most of the time it is going to be normal. And lastly, the most important diagnostic parameter in a patient with HHS becomes your serum osmolality, which is going to be greater than 320. Alright, however this table shows DKA versus HHS, you must understand that oftentimes you will see there is going to be a considerable overlap between DKA and HHS patients. They will have a mixed presentation. It does not matter to us whether it's a pure DKA, a pure HHS or a mixed picture. Reason being, your treatment is exactly the same.